Hello everyone, and welcome to another stream of Advanced Pharmacology. Today we're talking about Chapter 54, Antihistamines. Histamine is a small molecule produced in a specialized cells throughout the body. The compound plays an important role in allergic reactions and regulation of gastric acid secretion. The antihistamines, as widely used family of drugs, block histamine actions. To understand the antihistamines, we must first understand histamine itself. Accordingly, the chapter begins with the discussion of histamine, emphasizing its contribution to allergic responses. As always, my pages may not line up accordingly with the book's pages, but we'll be reading the chapter in its entirety. So we'll jump in with histamine. Histamine is a locally acting compound with prominent and varied effects. In the vascular system, histamine dilates small blood vessels and increases capillary permeability. In the bronchi, histamine produces constriction of the smooth muscle. In the stomach, histamine stimulates secretion of acid. In the central nervous system, histamine acts as a neurotransmitter. Despite this impressive spectrum of action, clinical use of histamine is limited to diagnostic procedures only. However, although its clinical utility is minimal, histamine is still of great interest owing to its involvement in two common pathologic states, allergic disorders and peptic ulcer disease. So, speaking of the distribution, the synthesis, storage, and release, the distribution, histamine is present in practically all tissues. Levels are especially high in the skin, lungs, and the gastrointestinal tract. The histamine content of plasma, however, is low. Synthesis and storage, therefore. In the periphery, histamine is synthesized and stored in two types of cells, mast cells and basophils. Mast cells are present in the skin and other soft tissues. Basophils are present in blood. In both mast cells and basophils, histamine is stored in secretory granules. In the CNS, histamine is produced by neurons with cell bodies in the posterior hypothalamus and with axonal projections to the frontal and temporal cortices and other brain regions. So how is it released? The release of histamine from mast cells and basophils is produced by allergic and non-allergic mechanisms. The allergic release, therefore, the initial requirement for allergic release is production of antibodies of immunoglobulin E class. These antibodies are generated after exposure to specific allergens. So your pollens, insect venoms, certain drugs. Once made, the antibodies become attached to the outer surface of mast cells and basophils. When the individual is re-exposed to that allergen, the allergens become bound by the antibodies. Binding of allergens to adjacent antibodies creates a bridge between those antibodies. By a mechanism that is not fully understood, this bridging process mobilizes intracellular calcium. The calcium, in turn, causes the histamine containing storage granules to fuse with the cell membrane and disgorge the contents into the extracellular space. Note that allergic release of histamine requires prior exposure to the allergen. An allergic reaction cannot occur during the initial allergen exposure. So here you're taking a look at phase one from the formation of the IgE. You have your allergen and your immune system, which leads to an antibody. Then during phase two, the binding of that IgE to mast cells. When you're looking at the mast cell, you have your secretory granule containing histamine and other mediators of the allergic response. And then you see those receptor sites of the IgE bound to the mast cell. In phase three, the release of histamine. So you're taking a look at that. Your non-allergic release. Several agents, such as drugs, radiocontrast medium, and plasma expanders, can act directly on mast cells to trigger histamine release. With these agents, no prior sensitization is needed. The cell injury can also cause direct release. So, the physiologic and pharmacologic effect, therefore. Histamine acts primarily through two types of receptors, named histamine 1, or H1, and histamine 2, H2. The response produced depends on which of these receptors is involved. So we'll start on the effects of histamine 1, the stimulation. The vasodilation, the activation of H1 receptors, causes again the dilation of small blood vessels, your arterioles and the venules. Vasodilation is prominent in the skin of the face and upper body, causing the area to become warm and flushed. If extensive vasodilation occurs, total peripheral resistance declines and your blood pressure begins to fall. And increased capillary permeability. The activation of H1 receptors increases capillary permeability. Receptor activation causes capillary endothelial cells to contrast, creating openings between these cells through which fluid, protein, and platelets can escape. Escape of fluid and protein into the interstitial space produces edema. If loss of intravascular fluid is substantial, blood pressure may fall. Your bronchoconstriction. Your H1 activation causes the constriction of the bronchi. If histamine is administered in an individual with asthma, severe bronchoconstriction will follow. However, although exogenous histamine can induce bronchial constriction, histamine is not the cause of the bronchoconstriction that occurs during a spontaneous asthma attack. Consequently, antihistamine are of no use for treating asthma. Your CNS effects. In the CNS, your H1 receptors have a role in cognitive memory and the cycle of sleeping and waking. In addition, your H1 receptors appears to have a role in seizure suppression, modulation of neurotransmitter release, and the regulation of energy and endocrine homeostasis. Other effects. Activation of H1 receptors on the sensory nerves produces itching and pain. H1 activation also promotes the secretion of mucus. The effects of histamine 2 stimulation. The major response to the activation of H2 receptors is the secretion of gastric acid. Histamine acts directly on parietal cells of the stomach to promote acid release. Although acetylcholine and gastrin also helps regulate acid release, histamine has a dominant role. We know this because in the presence of an H2 blockade, acetylcholine and gastrin are unable to elicit acid secretion. So the role of histamine in an allergic response. Allergic reactions are mediated by histamine and other compounds, usually those prostaglandins, leukotrienes, and tryptase. The intensity of an allergic reaction is determined by which mediator is involved. The symptoms of a mild allergy, so like your rhinitis, itching, localized edema, are caused largely by a histamine acting at the H1 receptor. As a result, mild allergic conditions, so your hay fevers, your acute urticaria, mild transfusion reactions, are generally responsive to antihistamine therapy. The two types of antihistamines, histamine 1 antagonists and histamine 2 antagonists. Antihistamines fall into two basic categories, your H1 receptor antagonist and the H2 receptor antagonist. The principal use of H1 blockers is treatment of mild allergic disorders. The principal use of H2 blockers is treatment of gastric and duodenal ulcers. Because H2 antagonists do not block H1 receptors, these drugs are of no use for treating allergies. In this chapter, we will focus on the H1 antagonists, and the H2 blockers, which are widely used, will be discussed in chapter 62. So, histamine antagonists, the basic pharmacology. The H1 antagonists are the classic antihistamines. Because of its historical use, the term antihistamine is still employed as a synonym for the subgroup of histamine antagonists that produce selective H1 blockade. Here we continue to use the term antihistamine interchangeably with H1 blocker and H1 antagonist. Although all H1 antagonists available have similar antihistaminic actions, these drugs differ significantly in side effects. Because of these differences, the selection of prototype to represent the group is not feasible. Thus, rather than structuring discussion around one prototypic drug, we discuss the H1 antagonists collectively. Differences among the individual antihistamines are addressed as appropriate. The classification. The H1 antagonists fall into two major groups, the first generation H1 antagonists and the second generation H1 antagonists. The principal difference between the groups is the first generation antihistamines are highly sedating, whereas second generation antihistamines do not cause that effect. The mechanism of action, therefore. H1 blockers bind selectively to H1 histaminic receptors, thereby blocking the action of histamine at these sites. H1 antagonists do not block H2 receptors. Also, they do not block the release of histamine from mast cells or basophils. It should be noted that, although the interaction of the classic antihistamines with histaminic receptors is limited to the H1 receptor subtype, these drugs can also bind to non-histaminic receptors. Most notably, certain antihistamines can bind and block muscarinic receptors. This action underlies several important side effects. So the pharmacologic effects, the peripheral, the major therapeutic effects of an H1 antagonist can be attributed to preventing the action of histamine at H1 receptors. In arterioles and venules of the skin, H1 blockers inhibit the dilator action of histamine and thereby reduce the localized flushing. In capillary beds, the antihistamines prevent histamine-induced increases in permeability and thereby reduce edema. By blocking histamine at sensory nerves, H1 antagonists reduce itching and pain. The blockade of H1 receptors on mucous membranes suppress secretion of mucus. The effects on the CNS. Antihistamines can cause both the excitation and the depression of CNS. At therapeutic doses, antihistamines produce CNS depression. Reaction time is slowed, alertness is diminished, and drowsiness is likely. These effects are more pronounced with some antihistamines than with others. With most second-generation antihistamines, such as your fexofenadine, your CNS depression is negligible. Overdose with antihistamines can produce CNS stimulation. Seizures frequently will result. Very young children are especially sensitive to CNS stimulation by these drugs. Your other pharmacologic effects, therefore, the blockade of muscarinic cholinergic receptors by antihistamines can produce typical anticholinergic responses. These are discussed later under adverse effects. Several antihistamines can suppress nausea and vomiting, as discussed later under motion sickness. So your patient-centered care across the lifespan, if we're talking about the antihistamines, your infants, antihistamines can cause sedation in infants, although they can be used in small doses in children older than 6 months. Caution should be employed. In your children and adolescents, antihistamines can be used safely in children, just in smaller doses. Side effect profiles are similar to those of adults. Promethazine is contraindicated in children younger than 2 years because of the deaths that have occurred in this age group. In pregnant women, there has been debate regarding whether antihistamines can cause fetal harm when used during pregnancy. Many of these drugs are classified in the U.S. Food and Drug Administration Pregnancy Risk Category C and should be avoided unless absolutely necessary. For patients who are breastfeeding, occasional small doses of antihistamines do not appear to cause sedation in infants. However, caution should be used. In the older adult, because antihistamines can cause sedation, smaller doses should be used initially and titrated up if needed. Also, these medications can cause glaucoma and benign prostatic hyperplasia. Worse, therapeutic uses. All of the H1 antagonists are useful in treating allergic disorders. Some are also indicated for other conditions, including motion sickness and insomnia. Your mild allergy. Antihistamines can reduce symptoms of mild allergies in people with seasonal rhinitis. H1 blockers can reduce sneezing, rhinorrhea, and itching of the eyes, nose, and throat. In patients with acute urticaria, these drugs can reduce redness, itching, and edema. The antihistamines can also reduce symptoms of allergic conjunctivitis and urticaria associated with mild transfusion reactions. In all these conditions, benefits result from H1 receptor blockade, not from preventing allergen-induced release of histamine from mast cells and basophils. Because mild allergic reactions may be mediated by substances in addition to histamine, antihistamines often fail to produce a complete relief. Your motion sickness. Some antihistamines, such as promethazine and dimethylhydrinate, are labeled for the use in motion sickness. Benefits derive from blocking H1 receptors and muscarinic receptors in the neural pathway, leading from the vestibular apparatus of the inner ear to the vomiting center of the medulla. Motion sickness will be discussed more in chapter 64. Insomnia. The ability of antihistamines to cause drowsiness has been exploited in the treatment of insomnia. Practically every over-the-counter sleep aid contains an H1 antagonist, your Benadryl and Pyrrolumine, as its active ingredient. However, although antihistamines can induce sleep when used in sufficient dosage, the doses recommended for over-the-counter preparations are usually too low to be effective. Leading us to the adverse effects. All of the H1 blockers can produce undesired effects. As a rule, these responses are more of a nuisance than a source of serious discomfort or danger. Frequently, side effects subside with continued drug use because individual antihistamines differ in their ability to produce particular side effects. Adverse responses can be minimized by judicious drug selection. So here you see the pharmacologic effects of the H1 antagonists used for parenteral therapy. So here you see the first generation of antihistamines and their sedative effects as well as their anticholinergic effects. A good spot to hit pause if you need to look at the list of all the first and second generation antihistamines. Sedation. Sedation is the most common side effect of the antihistamines and can lead to serious consequences. For students, sedation can impair learning and memory. For drivers, sedation greatly increases the risk for an accident. In fact, the degree of impairment seen with antihistamines equals that seen when blood levels of alcohol exceed the legal limit. Worse yet, impairment can occur without feeling tired. Accordingly, patients should exercise extreme caution when driving or performing other hazardous activities. They should also avoid alcohol and other CNS depressants, which will intensify the depressant effects of the H1 antagonist. Fortunately, tolerance to sedation often develops within a few days or weeks. If a preparation with a long half-life is being used, daytime sedation can be minimized by administering the entire daily dose at night. The second generation antihistamines exerts little to no sedative effects. First, these drugs are relatively large molecules with low lipid solubility, so they can't cross that blood-brain barrier. Second, these drugs have low affinity to the type of H1 receptor found in the brain. In contrast, the first generation antihistamines are relatively small molecules with a high lipid solubility and hence can readily cross the blood-brain barrier. In addition, these drugs have a high affinity for the H1 receptor in the CNS. For patients who experience disabling sedation with the first generation H1 antagonists, therapy with a second generation non sedating antihistamine is likely to help. Non sedative CNS effects. In addition to sedation, antihistamines can cause dizziness, incoordination, confusion states, and fatigue. Older adults are especially sensitive to these actions. In some patients, paradoxical excitation occurs, resulting in insomnia, nervousness, tremors, and even seizures. CNS stimulation is most common in children and after an overdose. Your gastrointestinal effects. Gastrointestinal disturbances are common. Responses include nausea, vomiting, loss of appetite, and diarrhea or constipation. These reactions can be minimized by administering antihistamines with food. Your anticholinergic effects. The H1 antagonists possesses weak atropine-like properties. These antimuscarinic actions can produce drying of mucous membranes in the mouth, nasal passages, and throat. Cholinergic blockade may also result in urinary hesitancy, constipation, and palpitations. If dry mouth becomes distressing, discomfort can be minimized by using hard sugarless candy and by taking frequent sips of liquid. Antihistamines should be used with caution in patients with asthma because thickening of bronchial secretions may impair breathing. Care is also needed in patients with other conditions that can be made worse by muscarinic blockade, such as urinary retention, benign prostatic hyperplasia, and hypertension. The second generation antihistamines are the least anticholinergic. We do have a black box warning on promethazine. Promethazine, also known as Phenergan, can cause severe respiratory depression, especially in the very young patients. Deaths have occurred. Accordingly, the drug is now contraindicated for the use in children younger than 2 years of age and should be used with caution in children older than 2. Severe local tissue injury. Extravasation of IV promethazine can cause severe local tissue injury, including gangrene that requires amputation. Severe injury can also occur with inadvertent perivascular or intra-arterial administration, or with administration into or near a nerve. Accordingly, when parenteral dosing is needed, the preferred route is intramuscular. Subcutaneous promethazine is contraindicated. Drug interactions. The central nervous system depressants. Alcohol and other CNS depressants, your barbiturates, benzodiazepines, and opioids can intensify the depressant effects of H1 antagonists. Patients should be advised against drinking alcoholic beverages. If medications with CNS depressant properties are combined with H1 blockers, dosage of the depressant may need to be lowered. The use in pregnancy and lactation. Pregnancy. The margin of safety of antihistamines in pregnancy is unknown. There are or have been reports of fetal malformation, but direct involvement of H1 antagonist has not been proven. Given the uncertainty of the safety of these drugs, it is recommended that antihistamines be used only when clearly necessary, and only when the benefit of treatment outweighs the potential risk to the fetus. Antihistamines should be avoided late in the third trimester because newborns are particularly sensitive to the adverse actions of these drugs. Lactation. The H1 antagonists can be excreted in breast milk, thereby posing a risk to the nursing infant. Because infants and especially newborns are unusually sensitive to antihistamines, these drugs should be avoided by women who are breastfeeding. If necessary, small occasional doses will likely not cause harm. Acute toxicity. Although the antihistamines have a large margin for safety, acute poisoning is nonetheless common. Owing to the widespread availability of these drugs, CNS effects are prominent, especially anticholinergic reactions. Specific symptoms and treatment are described next. Here's symptoms. The anticholinergic action of H1 blockers produce symptoms resembling those of atropine poisoning, dilated pupils, a flushed face, hyperpyrexia, tachycardia, dry mouth, and urinary retention. In children, CNS excitation is prominent, manifesting as hallucinations, incoordination, ataxia, and convulsions. In extreme cases, intoxication progresses to coma, cardiovascular collapse, and death. Treatment, therefore. There is no specific antidote to antihistamine poisoning. Hence, treatment is directed at drug removal and managing symptoms. Absorption can be minimized by giving activated charcoal, followed by cathartic. Convulsions can be treated with IV benzodiazepines, lorazepam, or midazolam. Hyperthermia can be reduced by applying ice packs or by giving sponge baths. So, preparations. As noted previously, the H1 antagonist can be divided into two major groups, the first generation H1 antagonist and the second generation. The first generation agents can cause significant sedation. In contrast, the second generation agents cause little to no sedation. All of the H1 blockers can be administered by mouth. In addition, some can be given parenterally, by nasal spray, or by rectal suppository. Routes and dosages for individual H1 antagonists are shown in the following table. So here's a good spot to hit pause if you're unfamiliar with the different types of antihistamines here, whether it's the first generation or second generation. And you'll also see the trade name, the route, and the use. Your first generation histamine 1 antagonists. The first generation antihistamines can be grouped into 5 major categories. These groups differ in the antihistaminic efficacy and the ability to cause sedation and muscarinic blockade. Given these differences, it may be possible through judicious drug selection to produce effective H1 blockade while minimizing undesired effects. Sedation can be a significant problem. Among the first generation agents, CNS depression is most prominent, with the ethanolamines and phenothiazines, and least prominent with the alkylamines. For many patients, the alkylamines can provide effective H1 blockade while causing only a modest reduction in alertness. If sedation remains excessive with an alkylamine, a second generation agent should be tried. Most first generation agents have significant anticholinergic properties. As a result, they can cause dry mouth, urinary hesitancy, and other typical anticholinergic side effects. Second generation, your non-sedating histamine 1 antagonists. Second generation antihistamines produce much less sedation than first generation agents because the second generation agents cross the blood brain barrier poorly and they have a low affinity for H1 receptors of the CNS. Synergism with alcohol and other CNS depressants are low. Nonetheless, combined with CNS depressants and the second generation agents should be avoided. In addition to lacking sedative effects, the second generation agents are largely devoid of anticholinergic actions. When these drugs were introduced, they all required a prescription. Now, 3 agents, cetirizine, fexofenadine, and loratadine, are available for over-the-counter. Because all of these drugs are very similar, initial selection can usually be based on price. If a cheaper agent proves ineffective, a more expensive agent should be considered. Descriptions that follow are limited to the 5 second-generation agents that are used for oral therapy. Two other second-generation agents, azolastine and olopatadine, both used for local effects in the nose, are discussed in Chapter 60. So, speaking of fexofenadine, also known as Allegra, is approved for oral therapy of seasonal allergic rhinitis and for chronic idiopathic urticaria. Of the second-generation antihistamines now available, Allegra appears to offer the best combination of efficacy and safety. In clinical trials, the incidence of drowsiness and other side effects was nearly the same as a placebo. Allegra has a half-life of 14.5 hours and is excreted unchanged in the urine. The drug is available in standard tablets, whether 30, 60, or 180 milligrams, and a suspension of 6 milligrams per ml. Marketed as Allegra Children's Liquid and as orally disintegrating tablets. For all formulations, dosage should be reduced in patients with renal impairment. Certain fruit juices, your apple juice, orange juice, and grapefruit juice, can reduce Allegra's absorption, possibly reducing therapeutic effects. The mechanism is inhibition of organic anion transporting polypeptides, which contribute to the absorption of Allegra from the GI tract. To ensure that Allegra absorption, patients should not drink fruit juices within 4 hours before dosing and 1 to 2 hours after dosing. Cetirizine, also known as Zyrtec, is indicated for allergic rhinitis and chronic idiopathic urticaria. The administration is oral and food delays absorption. Zyrtec is eliminated by a combination of hepatic metabolism and renal excretion. Its half-life is 8.3 hours, although Zyrtec is generally well tolerated and can cause drowsiness, fatigue, and dryness of the mouth, nose, and throat. Zyrtec and levocetirizine is its active isomer, cause more sedation than the other second-generation antihistamines, but less sedation than a first-generation drug. Zyrtec is available in standard tablets, 5 milligrams, and chewable tablets both in 5 and 10 milligrams, orally disintegrating tablets 10 milligrams, and syrup 1 milligram per ml. Dosage should be reduced in patients again with significant hepatic or renal impairment. Levocetirizine, also known as Sizal, is the levoactive isomer of cetirizine and shares the drug's indications: allergic rhinitis and chronic idiopathic urticaria. Like cetirizine, Zizal is more sedating than the other second-generation antihistamines, but less sedating than a first-generation agent. The most common side effects are drowsiness, fatigue, muscle weakness, and dry mouth. Alcohol and other CNS depressants can intensify sedation and hence should be avoided. Levocetirizine or Sizal is supplied in scored 5 milligram tablets and an oral solution of half a milligram per ml that can be administered without regards to meals. To minimize sedation, dosing should be done in the evening. Dosing should be reduced in adults with mild to moderate renal impairment, and children with any degree of renal impairment should not use this drug. Bringing us to loratadine or Claritin, which is approved only for seasonal allergic rhinitis. Like other second-generation antihistamines, the drug is generally well tolerated. However, in clinical trials, 8% of patients experienced drowsiness and 12% experienced a headache. Claritin is administered orally and food delays absorption. The drug undergoes extensive hepatic metabolism and has a half-life of 8 to 28 hours. Claritin is available in 5 formulations: a syrup of 1 milligram per ml, 10 milligram liquid gels, 10 milligram standard tablets, 10 milligrams orally disintegrating tablets, and 10 milligram rapid disintegrating tablets, designed to dissolve on the tongue. For patients with significant hepatic or renal impairment, dosing should be done every other day. And that brings us to desloratadine, or Clarinex, is the major active metabolite of Claritin. The two drugs differ primarily in that desloratadine, or Clarinex, has a longer half-life, from 27 hours versus the 8.4. However, although Clarinex has a longer half-life, there is no proof that its effects persist longer. Approved indications are seasonal allergic rhinitis, perennial allergic rhinitis, and chronic idiopathic urticaria. Clarinex has no significant drug interactions, and at the recommended dosage, the incidence of adverse effects is similar to that of the placebo. About 7% of patients metabolize Clarinex very slowly, causing its effects to be more intense. Dosaging for Clarinex in 5 mg standard tablets or 5 mg rapidly disintegrating tablets, and a syrup of 2.5 mg per 5 ml. For patients with liver or renal impairment, the manufacturer recommends reducing the initial dosage to 5 mg every other day. And that brings us to the completion of this chapter. So we'll see you all at the next one.